Good morning, everybody, and welcome to day 3 of TMF Week. My name is Kimberly Bruce, and I'm the marketing coordinator at Montrium, and we are pleased and delighted to welcome you back for day 3 and the first session of the day, which is the many changing faces of sponsor oversight and how TMF fits in. So we're very excited about this lineup that we have today. But before we get to session 1, would like to go over some housekeeping rules. So we encourage you to ask questions throughout the presentation because this is what TMF Week is all about. It's about learning. It's about getting your answers, getting your questions answered. So please feel free to put it in the chat and Q&A section. There will be a poll in this presentation, so please go to the poll section at the top right corner to select your option. Questions will be answered at the end of the presentation, so there will be a Q&A section at the end. All sessions will be recorded and available after the session ends, so be on the lookout for that. And just to let you know, day 1 and day 2 sessions are already up, so you can look at them. If you have missed anything, don't worry about it, we got you. You'll be able to look at these presentations. All attendees will be receiving attendance certificates, so be on the lookout for that. Well, probably 7 days after the event ends. Networking breaks, we encourage you to do that. That's, again, what TMF Week is all about. It's about connecting with your colleagues and peers, and also, you know, talking to experts and leaders. So go make sure to visit the virtual booth and just, you know, be able to like converse with them. So today's speaker, very pleased, is Daniel Bennett. He's an independent TMF manager, and Daniel has worked in various TMF roles for large pharma companies and small biotech with a full-service CRO and a specialist TMF provider. Having seen the issues from all sides, he is a convert to the idea that the TMF is a key part of a quality approach to clinical trial management. He was very involved with the development of version 3.2 of the DIA TMF reference model and is excited to see and talk about how companies make use of the changes to deliver better quality TMFs for better oversight. So without further ado, I'd like to pass the mic over to Daniel, and that will be all. Hi, Daniel.
Hi, Kimberly. Thank you very much.
Excellent. So I'm going to share my screen so we could put up your wonderful presentation.
Here we go.
Perfect. Okay, the floor is yours.
Thanks very much. Pleasure to be here. Wonderful to be talking to you all. I've been enjoying the other talks already this week. I hope you have too, and I hope that continues for the next 30 minutes or so, and then beyond with other people. So today's topic, sponsor oversight and the TMF. Now I should start with a customary disclaimer that these are my views, not those of my employer, present, past, or indeed future. So blame me. Hopefully you find a couple of things of interest to make you think. I'm not necessarily saying this is the law, not laying this down to you, but maybe there's a couple of little provocations you can take away and make something useful from. So on this topic, let's start just by thinking about oversight a little bit. And just to be clear, I'm not talking about the first definition here, the unintentional failures. That wouldn't be, well, I mean, that would be a very interesting talk, but there are various issues about the kind of confidentiality. So we're on the second one there, the action of overseeing something, which seems better than the first definition, but actually if you stop and pause for a moment, it's not terribly helpful. Oversight is the action of overseeing something. Yeah, terrific. So can we get a little help with that? Well, let's slip the definition of what overseeing is in there. And so now finally we have something useful. It's the action of officially supervising a person to ensure, or people, to ensure that their work is done properly. And it's about making sure the work is done properly rather than the sort of line management or personnel development or running a team or anything like that. It's about making sure the work is done properly. Why would anyone care about this? Well, as you see in the little box at the bottom, it's part of the R2 revision. There's a bit been added in section 5, which is about sponsor responsibilities. The sponsor shall ensure oversight of any trial-related duties and functions carried out on their behalf. So you got to do this. The GCP tells us so. You've got to ensure oversight. There is one tiny thing to notice there, that you have to ensure oversight. You don't have to do all of the oversight yourself, is the way it's written. Having said that, what are we overseeing? Well, to no one's surprise, what I'm talking about here is the oversight of a clinical trial. It's very easy, if you just talk about oversight or sponsor oversight, it's very easy to start talking about how you're going to oversee a vendor, or how you're overseeing a process, or an issue, or a site, or how are you overseeing your TMF. Vital things, important things, good topics to talk about, but really important equally to know when we're zooming in and when we're talking about the big picture. When are we talking about oversight of the clinical trial, which is, after all, what the definition on the previous page said, all or any activities on their behalf. So it's everything, oversight of everything. How are you keeping an eye on the whole trial? And my first takeaway from this talk, forgive the visual pun, is that oversight is an undelegatable task. You can delegate oversight of the trial to let's imagine a situation where you're delegating it to a full service CRO. You delegate that oversight, and that seems only right and proper. You hire a CRO to run a trial for you. I would very much expect they have someone, perhaps a project manager or a project director, who is going to sit on top of that, their work for you, and oversee it. Of course, they're going to do that. Terrific, right and proper. But you must still oversee them. The sponsor remains accountable. So you've delegated it. It's like a magic trick. You've delegated it, but you've still got it. And this would be equally true if you brought in someone else to do the overseeing for you. So if you created a new role, the clinical trial overseer, to oversee your full service CRO, and I can imagine that this would be something people might do, to have a view over the whole trial and to report on how it's going from a sort of external, one step removed point of view. You'd still have to oversee them, because they're also now part of the trial. If you add something new, you add more responsibility to oversee it. The complexity only grows as you add things. The same is true for vendors. For vendors, CROs, and TMFs, that you can delegate oversight of these things, but you then have to oversee the overseer. Before I crack on with sponsor oversight, a small digression on responsible and accountable, words which have appeared already. This is what I learnt when I was working in a quality department. Obviously, this is not like a universal law. Words are used differently by different people at different times, and that's fine. And of course, we work to understand each other. But one of the things I understand by these two words is as follows: that responsibility is about doing something, and so I like to say that it rolls down an organization, when things are delegated, like a football rolls down a hill. So for example, if someone very senior in a company needs a form filling in, they delegate it to someone who delegates it to someone who gives it to a team member who gives it to an admin assistant who fills in the form. Only one person has filled in the form. The football has rolled until it's at the bottom. It's no longer at the top. Whereas accountability is slightly different. Accountability is about whether you're in trouble if it doesn't get done. So to put it negatively, or more positively, it means you're in charge of ensuring that it gets done, which takes us back to that ICH GCP E6 definition. Accountability rolls down an organization like an open tin of paint rolls down a hill. I mean, yes, it gets to the bottom, but you can tell how it got there. You can see it all the way down, and some of it, frankly, has remained at the top, which is slightly different to what you sometimes hear about accountability, because you sometimes hear that only one person is accountable. And let me be clear, again, people use words differently, including when they wrote GCP, ICH GCP 6, because they say responsible, where I would say accountable. which is awkward for the purposes of this, but here's the point. There are times when this is true. Only one person is accountable to the regulator or authority, and that's the sponsor. And that's always true. You can't delegate that accountability, that accountable relationship. The sponsor answers to the regulator. And only one person is indicated as accountable on a RACI. So if you're drawing up a task matrix to show who does what and how people work together and how information flows between teams and so on, then you only want one person to be accountable for it, because otherwise the two people who are listed will leave it to each other and it won't get done, and that's problematic. So for that reason, you tend to just have one. However, this is not the whole truth. This is not the only story. There are other things going on too. Quick example, again, drawing on ICH GCP's R6, E6, sorry. The sponsor shall ensure that the trial is adequately monitored. Well, that's perfectly clear, but we all know absolutely that this does not mean that the directors of a pharma company go to the site and do source document verification. It's just not how it works. It's not what it means. So we can add more detail to the picture, and apologies for far too many words on a slide, but the point here is there's a lot you can say usefully and helpfully, and I won't read it to you, I won't labor the point, but I've drawn out in different colors the fact that it's helpful in this context to be clear about accountable to whom and for what. So it's always true that the sponsor in the the board, the directors, the owners of the sponsor are accountable to the regulator, but they employ senior managers who employ middle managers who engage in contracts with companies that have people that run teams which delegate tasks to people who actually do the work. And so you can see that here. And all of these people are responsible for the things they do, and everyone is accountable for the things they do. So little digression there into responsible and accountable to help you understand what I mean when I say that accountability is undelegatable. Second takeaway, oversight then is, at least in part, it's about the way that responsibility and accountability flow down the organizational structure. You need to document this. You set all this out in your quality management system, in your business structures of how that is set out. And I reckon it's probably quite complex, particularly if you're a big pharma, but even if you're a small biotech, there's a degree of complexity. We are talking about putting experimental medicines into people and seeing what happens. There is inherently in that a degree of complexity and scale. Obviously, there's two ends of the scale. There's small trials and there's big trials. There's simple trials and there are complex trials, but there is inherently a certain complexity. Clinical trials are complex, and so they need really big, strong systems of accountability and responsibility. And you have to work hard to create those, and you have to then follow them, and you have to document that. But you also need great flexibility, because no matter how complex you make your systems, I bet the world will outdo you. I bet when the trial starts, I bet reality bites you and it all goes sideways and something else happens. So you need flexibility as well there. And both of those things, both the rigid system and the flexibility that you use it with, are then going to create an awful lot of written records. People say they want simplicity, and I understand that. I'm not thinking that's a bad thought. In which case, design simple trials and design simple processes. That feedback needs to go into the people who are building your processes and writing your SOPs and your how-to documents. As long as we have complex trials and complex processes, oversight of that trial is inherently going to be a complex thing. So, to crack on to the core of the subject, it won't surprise you, both from what was said in the introduction and from what I've just said, that the foundation of oversight is found in your quality management system. In section 5 of GCP, it talks about taking a risk-based approach to quality management, and having elements of QA and QC within your quality system, which refers to the clinical trial. And we're expecting with R3, with the next revision, that there will be even more focus on quality and quality by design, and starting from quality and intent of quality. And just to call out a couple more items here, we have the quality management plan, which is the name given to the document in the DIA reference model. But as ever with these plans, you can move the content to a different plan. As long as the content is there, it's fine. So you might be talking about non-compliance and issue management. And issue management sort of blurs into communication and escalation. And escalation and communication are often found as part of the trial management plan. And so rightly, often quality is kind of folded into the trial management plan. So without getting bogged down in the details of document standards, this might be in quite a lot of places. As long as it's there, that's fine. Doesn't really matter what it's called. The foundations are hidden, so to speak. As long as they're there, that's fine. So the foundation is built on quality. The first set of pillars, here we have the front of the building. The first set of pillars is vendor management, sometimes referred to as third-party vendors, which I'll comment on the next slide. I kind of think I have these slides the wrong way around, but no matter. And just for a second, let me pause and say vendor selection might be the most important part of a clinical trial. Obviously qualifying that with patient safety. Patient safety is the most important part, but then maybe vendor selection is just following that. You choose the right vendors, your trial may go very well. It might be very effective, very quick, and very cheap, and that might be wonderful. You choose the wrong vendors, and your trial might be really difficult. So in the same way that for most companies, who they employ is kind of important, so it is with vendors. You've got to get the right one. And then we have the other things that you do with vendors there, including oversight. So you have to oversee vendors as part of overseeing the trial. It seems obvious, but in fact, it's sort of an unpleasant sentence to say. So it sometimes gets left unsaid. Critically appraising the performance of your vendors and communicating that to them, and obviously documenting that as part of the story of the trial. You'll see also there a note on sub-vendors. Vendors are people who are contracted to the sponsor. Sub-vendors are taking part in the trial, but they're not contracted to the sponsor. They are presumably generally contracted to the full service CRO, to a vendor. CRO is a vendor. And so there are things you might not see in that relationship. You might not see the financials. You probably don't need to see the daily back and forth, the phone calls that just say everything's fine, it's exactly like I said it would be, and all that stuff. You don't need to be involved in that. But that's a problem, because we brought more people into the trial, and we're getting less information. That can't be right, because inherently you would think, well, let's keep doing it. Let's add more and more and more sub vendors in a cascade until eventually we're not doing any. And that doesn't work. So what you get instead, in place of what you miss, is there should be some evidence of the vendor overseeing the sub vendor. There should be evidence of them managing the people to whom they have delegated. And as I say, I understand that you're not going to see everything, but you are going to want to see something. That was, in fact, in a regulatory inspection finding from, I think, 2018. I think it's not the latest ones, but I think it's out there from the year before, that there was no evidence of the vendor overseeing the sub vendor. So that's one key area, vendor management. This on the side of the building here, we have site management, and again, this for anyone who like me wondered, third parties. Who are the first two parties? Well, it's the sponsor and the site, I believe. It's a legal term, so there is a contract between the sponsor and the site. They are the two parties who undertake the trial by contract. That would be the CTA, the clinical trial agreement, often, and the protocol. So that's parties 1 and 2 together doing the trial, and then the vendors come in as party 3. Anyway, selection, again, absolutely vital. Get the right sites, that's the ones with the patients, and it will go really good. Get the wrong sites, which could cover a lot of ground, obviously, and it's going to be really, really difficult. Now, some of you might be ahead of me here, particularly at TMF Week, in noticing that I'm naming sections of the reference model. And indeed I am. There's a reason that they're sections of the reference model. It's because there's regulatory requirements to document and record and keep this stuff. And so overseeing them is likewise important. You can use the reference model index as a first effort guide to what do I need to oversee? Well, you need to oversee everything you're keeping. What do I need to keep? Well, start with the reference model. Actually, you need to keep everything that describes the trial, and you need to keep the things which are described in your quality system. But as a starting place, the reference model is ACE. You may be wondering, where is data management then and IMP? Well, I reckon that's on the previous slide. Those are things that are very commonly going to be delegated to a vendor, specialist, or generalist. And so you're going to be overseeing data management by overseeing your vendor who is doing data management. Here's the back of the building. This is my favorite slide in the deck, if anyone wants to join with me in enjoying it. What we have here is how we deal with the things that are the subjects of news, of updates, of meetings and discussions and communications. All the things that we spend a lot of time talking about, informally and more formally in meetings. And there is a cycle here. The arrows are important. That something happens in the trial. There is an event, and that creates information. And that information has to go through the right channels to the right people in order that they can take the correct actions that mean that the next event is moving in the right direction. So a quick example, a patient is screened at site. That's information. It goes into the relevant computer system and becomes data. And someone is perhaps counting how many patients have been screened, so we get metrics. They report on that to their boss, to the person who's running the trial. And then there's a report. The team, the clinical team then perform analysis and say, well, how's it going? Are we getting enough people? Is this what we expected, or is it slower? Is it quicker? So they come to a conclusion that recruitment is lagging. And so they make a decision. Let's open more sites. So they research more sites, or they do feasibility in another country. And that leads to action, and that leads to more information. And my point here is, how does the sponsor oversee that, and how do they document it? Key point here, to take away, chicken nuggets this time, is that oversight is about the way that information flows up the organizational structure. So the counterpoint to delegation and responsibility and accountability flowing down is, how does that information flow up the organizational structure? And because it's TMF week, and because I'm a huge fan of TMF work, having done this for sort of 7 years, I'm going to say that the unifying concept of oversight is records management. Specifically, in the case of a clinical trial, that would be the trial master file. So joining all these pillars together, and at this point I appreciate it's going to be a very funny looking building architecturally, the TMF joins all this stuff together. There are 2 points here, which, for reasons that escape me now, I labeled 1A and 1B. There are more conventional ways to label 2 points, which is that as the CRA is doing stuff, as they're running the trial, they put documents in the TMF. Terrific, that's good practice. And at that point, the sponsor can see them, and so they can oversee them. And that's point 1. The timely filing of documentation enables the sponsor to oversee in real time, or near real time, or promptly afterwards, which is appropriate. When you're talking about documentation, it is inherently, quite a lot of it is going to be after the fact. You are going to document what happened, rather than kind of write documents about the future. You know, I know about plans. I'm familiar you can document the future, but often you are after the fact. So it's a question of, is it soon enough after the fact rather than strictly contemporaneous? But the second point is that the oversight, the act of oversight, has to leave a record in the TMF. This is a situation, this concept of sponsor oversight is a situation where we can say, if it's not written down and filed properly, then it didn't happen. The sponsor oversight has to leave records in the TMF as well. We have a little mug here with this written on. These are available in the gift shop after the talk, but cheers, by the way. So that's the second point. Point one, the CRO has to put documents into the TMF. I think you know that. Point two is, don't miss the fact that there should be similarly evidence documents that prove sponsor oversight. What we're looking for is we want the sponsor to leave footprints, permanent footprints. This is an example of someone who has laid some concrete and stood in it, and so you can see the shoes they were wearing when they did that. To help us think about that, what I'm going to do is I'm going to just look at some common pitfalls, things that might befall you in a clinical trial. Here's number one. You've hired a full-service CRO, and they're wonderful, they're great, and they've got a lot of experience, terrific, and great people, and awesome systems, and they're using those systems, and they don't automatically give the sponsor access to those systems. I'm talking of, for example, the regulatory system, the safety database, the CTMS, the project management tools that they use to prepare timelines and project plans, resource management. All good stuff, perfectly reasonable they'd be using these things, and I understand why they wouldn't give the sponsor access. I get it. I've worked happily in this situation for a while. The problem is, if the sponsor doesn't have access to these systems, then they won't do anything in them. They're not taking part. They're not leaving evidence because they're not doing anything in the system. And so you create the need to create extra documentation to demonstrate oversight, which is a burden and a nuisance and the sort of things that sponsors don't want to do. They want to oversee the trial in a way that naturally creates evidence. They don't want to oversee the trial in a way that is like walking through the shallows here. They want to do the oversight and leave a trace, not well, in this situation, perhaps you've walked in a situation like this, but as soon as you lift your foot, the sand flows back in and no trace is left. So watch for that. Systems that you don't have access to can be problematic. You can be doing the oversight, but there's no indication that you've done so. Similar story with pitfall number two. We have a tracker. Awesome. It's good, you know, the site startup tracker, we're familiar with that. It's a beast, it's a big thing. What you need to be aware of there is that that document is used for different purposes by different people. So for the CRO, it's a terrific tool to organize work and to record all of this. It'll help them order and prioritize, it'll remind them, it'll coordinate, it'll schedule, and they can use it to communicate. And they can use that to provide oversight and insight and information to the sponsor. They can update and inform them. But 5 years later, when it's in the TMF and an imaginary inspector comes and looks at it, it only shows one side of that. It only records that the CRO created this document and did it. It doesn't record in any way that the sponsor was involved. Did they see this? Did they comment on it? Did they help? Did they take part in the trial? This is analogous in some ways to that old problem of consolidating a paper TMF at the end of the trial, that if you combine it all together, you lose a lot of contextual information. Well, here's an example of where that happens with electronic systems as well, that yes, the document is filed, but it doesn't show all the uses that the document was put to, different uses for different people. It's a bit like this. You're doing the oversight, and again, you can go out of your way to document it. So you can take a picture of your footprint. You could have a piece of paper and record that, you know, today I, the sponsor, examined the startup tracker. I particularly paid attention to the delays in Canada, and I made the following recommendations. But this is the kind of extra bureaucratic document work that people object to and don't do reliably or regularly. So it's a pitfall. Beware of looking at other people's trackers. Find a different way, find a different process, find a different system. Third worrying pitfall, the CRO says to the sponsor, I can send you that in an email. And now, don't get me wrong, along with all this other stuff, there's good here. I like email. Email's important. It would have been very difficult to do the last 18 months without email. Can you imagine? Gosh. Likewise, trackers, important. But they're not ideal. Email is not ideal for other stuff. So in many cases, if a CRO says this, the response should be, please don't do that. Rather, send me a link to the TMF or send me a location in the document management system, the file share. Show me where remind me where this information is. It'd be nice if I could sort of work out from first principles where it should be. But failing that, if you are going to share it with me, communicate with me that information. Communication has a role in oversight. This is not going to necessarily be a popular view, but I actually am moving towards the idea that distinct from the stuff you file in the TMF system, which all matches the index and has a very specific purpose, that you might also batch file your emails. In some properly validated and sorted out system, you might keep all your emails and just have them in date order and say to the inspector, full transparency, here is all the talking we did. The talking was an important part of the coordination and oversight of the trial. It's risky. There are issues there. It's not the way we did things in the past, but life is changing, and email search functions are a lot more powerful than they were 10 years ago. So possibly. There's another problem with email, which is that, again, it doesn't demonstrate oversight. And that an email has been sent is very limited proof well, it's not proof it's been received, it's proof it's been sent. Was it sent to the right place? Was it received? Was it opened? Was it read? Was it understood? Did that lead to any action? It doesn't leave traces of any of that sort of stuff. So yes, communication is an important part of oversight, but emailing stuff to the sponsor is a bit like emailing stuff to the void. I don't know that it proves quite as much as people think it does. It's like walking on the sand. It blows away. Your email will blow away. It'll be gone one day. Pitfall number 4. CRO processes that don't involve the sponsor. It's processes and the descriptions of those processes, the process documents. So for example of this, I, not so very long ago, had to read as a sponsor representative, in order to get access to the TMF, read-only access I should add, very limited access, I had to read all the SOPs on how to be a document specialist for that company and watch several videos, all of which were completely irrelevant to the role of the sponsor in oversight. I just want to look at my documents, thanks. Additionally, I've worked in this system before, and as it happens, I've done the job that you're sending me the SOPs for. It was a complete waste of time. The process didn't match the requirement for the sponsor role of oversight. There are other examples from the wider systems as well. Another example is review. It's terrific that a CRO, when they're reviewing a document, will involve the sponsor in review, have some input, terrific. But unless you're filing the red line edited versions with all the comments on, which is inherently risky for other reasons, this isn't going to leave any evidence. All that will be left in TMF is version 1, version 2, version 3. It magically changes between those versions. Was the sponsor involved? Well, they can sign it. You can sign it. You can sign it and say you've reviewed it. But is that really evidence? Did you, for example, just correct a couple of spellings and not really care about how the trial was run? It's not known. It's like this picture here. You could have an excellent trial, wonderful. It came in under budget, much quicker than anyone expected. All the patients were tremendously safe. and the drug was very effective, so they've all recovered fully, which is wonderful. But the trial was done completely by the CRO, and that's going to raise a problem that was the sponsor actually involved in this trial? Did they oversee what the CRO was doing? Well, you need evidence. And finally, pitfall 5, the CRO will do quality control, or at least they'll claim they do. And again, nothing wrong with this in its own terms, but is that then shared with the sponsor? And if it's shared with the sponsor, shouldn't evidence of that go into the TMF? So aren't you going to end up sharing it with the inspector? And that's problematic because you hear things like, oh, we keep that in our business records, not the TMF. We don't want to air our dirty laundry in the TMF. And I understand that. But if it leads to nothing being in the TMF, that's problematic. From the other side, you hear the sponsor saying, well, look, we're paying them to do this work and to check it. We don't want to duplicate it. We're not going to check their checking, so we don't need to see it. And again, I understand that. But if it results in no evidence of sponsor oversight in the TMF, then you have a problem. The takeaway here from that last one is I would suggest when selecting a CRO, when working with a CRO, have a read through of the SOPs that is about how will sponsor oversight be documented in the TMF. If you put down an SOP and you can't say, well, document X, document Y, and document Z will have our handprints, our fingerprints all over them, our input, it'll be clear that we were involved, then you have a problem. Obviously, there are other reasons to read SOPs. You want to know what the CRO is doing, and you want to know what rules, what regulations they are following, valid, important. But there is also a third reason, which is what documents will it leave. So I'm just going to finish off the last section here. I'm going to have a go at predicting the future. Seems to be popular this year. Everyone's having a go at this. And in fact, this will sound similar to what other people have been saying. But here we go. I'm going to start with an easy one. Extrapolating from where we are now, but I reckon that there will be computers involved in clinical trials over the next few years, robots even, artificial intelligence, and they're going to do things like start filling in the forms for us, which is great. That was mentioned by the sites yesterday, and they're going to file documents. They're already pretty good at this. I said it was easy. I'm really just telling you what has already started, what is happening. They're pretty good at learning they can identify documents from their title. I've always wondered why we don't put the filing location in the footer. I think they'd be pretty quick at picking that up as well. And eventually, over the next 20 years, they will learn to do contextual quality review of the TMF. They're not there yet. That's a difficult task. There will also be integration of the various systems that we use, and this has also started, but I'm predicting a sea change, a step, a total change. So instead of having multiple systems that can be bolted together or work together, I'm saying there will be a single platform. This will also address some of the issues that have been mentioned previously, for the following reasons: that this clinical trial system will be owned by a sponsor. It'll be part of becoming a sponsor. Will be you choose to use a system, and you'll then buy in a CRO that provides a service rather than various softwares. And what that means is that sites will then be able to have a portal that could work with multiple of these systems. So, because that's the big break on integrating systems across the sort of site sponsor divide, is a site might be working with any number of sponsors and have limited interest in investing in getting on board with one company. And the idea that every sponsor will agree on what to use seems unlikely. So the simplification, I think, will be that sponsors just have one system, and the only integration that you have to do will be between the sponsor system and the site system. But again, forgive me, I'm speculating wildly. One of the things this system will be able to do is is as follows. It will hold all these various parts. So the system will know the rules from the QMS. It'll know the details of your trial from your protocol, from your CTMS. It'll know information about the sites, which countries they're in and which regulations apply. And it will know who's in the team and what roles they're playing. So, for example, in the context of the how shall we write a protocol amendment SOP, instead of saying, if you're operating under an IND and there is a pediatric plan, then you'll need to do this, unless you're working with oncology, in which case this person needs to, well, I say oncology, there's two roles, there's translational and there's non-translational. Hugely complex. You'll just have a document that actually answers all those questions. You know, are they true or not? Are you in Europe? Will you need the QPPV to sign this off? All those questions will be answered. And so the document will just come out and it will say, medical writer John Smith writes the protocol, project manager Flora O'Donnell kicks off the review process, etc. So we'll get specifically applied SOPs that apply to particular cases, which delights me and excites me, but perhaps, you know, highly tailored SOPs perhaps isn't everyone's joy. But let's go to some questions and hear what you guys want to say or ask me about any of that. Thank you for listening. Yes, there is an email address on there, should any of you feel the need to email me after this.
Excellent. Thank you so much. Daniel, we are going to take some questions, and I'm just going to ask you to remove the share screen option so I can.
Yep. Now, where do I do that? This one? There we go.
There you go. You got it. Okay. So here we go. So now we're in the question period over here. And thought it'd be interesting to actually run that poll because you did talk about pitfalls. So we're just gonna we're gonna go live with the polls. If you guys can go into the poll section at the top, and it says, which pitfall do you identify the most with? Pitfall number 1, systems to which the sponsor does not have access. Pitfall number 2, we have a tracker. Pitfall number 3, I can send it to you in an email. Pitfall number 4, CRO process that don't involve the sponsor. And pitfall number 5, quality control by the CRO. So we're just going to let that run for a bit. Just remember the poll is running. It's at the top right corner next to the Q&A icon. So we just want to get some feelers there. A very good discussion, Daniel. And we do have a couple of questions here. If you have a CRO handling one or more of your studies, whose TMF plan should be used?
So you can make a case for both. It's very likely that if you're using a CRO and they're bringing a TMF system with them, that they will have text that they want and reasonably need in the TMF plan to describe that. On the other hand, you're the sponsor, you're going to set the standards for the trial, you're going to have expectations. So you're going to have some text that you want to bring to the party as well. And honestly, a bit like moving stuff between plans, it kind of doesn't matter. You could have two plans, one in which the sponsor lays out their expectations and the CRO says, yeah, okay. And then in the other one, the CRO then says, this is how we're going to do it. And the sponsor says, yeah, okay, sounds good to me. Or you could spend some time combining that text into one document, which would be a sort of combined plan. That can be difficult with timing. It can be difficult. It's at the start of the study when everyone's really busy, and somehow editing text in a TMF plan never feels like anyone's sort of key activity this morning. So it can be operationally and just practically, pragmatically, it can be quite difficult to get that done, which would be the argument for having two plans. But ultimately, if you have a combined plan, or if you just say, you know, it can depend on your size and experience as well. If you're a small biotech and it's your first study, you might not have very much to say about the TMF. So you might just have a few sentences that goes into the CRO plan. That's the way it is. Equally, you might be a really, really big, experienced pharma company, and you might have a really excellent TMF plan from which you will not deviate. And so it might be that you absolutely insist. So honestly, either is fine. The slight note to that is that the sponsor may have a slightly bigger view of this TMF, as in, these are all the records I'm keeping, not just the stuff which is in the CRO's TMF system. So CRO TMF plans are often actually about the CRO's TMF system and its content, which is, key and important and can be much of the TMF, but it's possibly not all of the TMF. So sponsor might want to add some surrounding information, or they might just want to keep their own document that they've already got.
Excellent. Thank you very much, Daniel. And the poll is in, so if anyone wants to check that out, it seems that pitfall number 2 is in the lead at 31.8%. Somebody actually commented, why can't, there should be an option where it's all of the above. I thought
Yes.
that was kind of funny there.
I have a tracker that we've exported from the safety system that I'm going to email to you.
Okay, perfect. So we are actually out of time. So we just wanted to say thank you very much, Daniel, for the presentation. If we missed any questions, we will be able to answer and get those answers out to you. We have the email address of Daniel. The next session will be Trial Master Files, TMFs through the eyes of a clinical study associate with Nicole Weigel. And that's coming up at 10 a.m. So now it is time for networking lounge. So head over to the lounge and chat with your peers. Like we said, TMF Week is about connecting and meeting new people. So please head on over there. And just want to say thank you once again, Daniel, and thank you to everyone that has joined the session. Have a great day.
Thank you, everyone. Thank you, Kimberly.
Thank you.